Okay, no mystery on the diagnosis, so I won't keep you in suspense. I have no disclosure. So basically, gastro-bronchial fistulas are very rare after weight loss surgery. Etiology, get a leak, that becomes a collection, possibly an abscess. The abscess traverses the diaphragm, either through erosion or iatrogenically, and then once the pus touches the visceral pleura, you get erosion into the airway. The special cases I won't really get into, but basically those are the iatrogenic cases, either drainage percutaneously or actually leaks treated with stents are a large proportion of the reported gastro-bronchial fistulas. Incidence, I think it's, there's two papers there that called it both 0.2, but I think using the MBSA QIP data, a lot of us probably quote about 0.2 as a primary leak rate, and then this is such a small subset of leaks, most commonly seen in sleeves. Roux-en-Y gastric bypass, most of those were revisions, which is the case I'm going to present, and I think it's always important just to have a high index of suspicion because pulmonary symptoms are often the presenting symptom, and it's often months, average of 7.2 months after an index procedure that patients start coughing up food or potentially clips. So, all right, this is a 36-year-old female who had a gastric bypass revision for weight gain and leaked, and then the leak was repaired, drained, and about 4 months post-operatively, she developed pneumonia, got this x-ray. The physician also got an upper GI just to check her anatomy, and you can see that the ingested contrast fills this cavity here and then kisses the bronchial tree and gives you this really nice bronchogram. It's a really cool x-ray, but I guess glad it's not mine.
We need this x-ray in the ASMBS textbook of bariatric surgery, so can you contribute?
Well, since I got your email this morning, I guess I'm on the spot here to yes, I'll contribute.
Good job. So let's see what the panel will say.
Well, let me show you the CT. So the CT here to follow, let's go from right to left. So you can see this patient's actually already drained at this point, but you terrible left upper quadrant here where the diaphragm should be. There's no real discernible plane. And then when you go up into the airspace, you have basically fluid and consolidated lung replacing airspace. So these are the basic management choices. Antibiotics and supportive management. So for the purpose of voting, let's just assume that everyone is going to choose the first one. So let's call A percutaneous drainage only or operative drainage only. Let's call B adding a stent to the drains, and let's call C going right to the operating room to do something.
Go ahead and start, texting your A, B, or C.
So A is drains, B is stent and drain, and
operative revision.
C is operative revision. And I'm going to keep going while people are voting, if that's all right, with 6 minutes. So cool.
Go for it.
Nope, I'm not going to keep going. Can't advance.
Still have pneumonia?
So the pneumonia really didn't clear up. It's a good point that if patients do have pneumonia, you have to treat the pneumonia, and then the other thing is really source control, and so and that's where you work on the drainage. And one of the things about managing this complication. It's not really, I can't give you an algorithm, or I don't think anybody can give you an algorithm of what's known to work. Rather, it's like it's what's your best bad option, because all of these are not great options, but the key is source control. And this is a reference that's actually pretty good in the scarce literature that goes through some of these things. The safe start is you treat pneumonia or sepsis with antibiotics, so I think everybody should be on antibiotics. And you have to drain the collections, and if you can drain them percutaneously in the abdomen with a chest tube in the chest, since most of these patients will eventually come to some operative intervention, or many, I should say, will come to some operative intervention, you're better off not burning bridges. What was the final tally on the vote before you clicked away?
Stent and drain, I think, was the B.
Stent and drain, excellent. Okay, 10% just drains, and then 13% right to the operating room. So that's actually about how it breaks down. endoscopic treatment actually might be successful in up to 90%. So this patient did get a stent, got stented and drained, and neither of those actually worked. And part of the stenting issue is what's been already talked about with sleeve leaks, is that you can cover the point of leak with a stent, fibrin glue, with mixed results, but the balloon dilation to make it from a high pressure system to a low pressure system and relieve the relative distal obstruction is really something to contemplate, because if you have a narrowing below the leak, you're never going to get a stent to fully seal the leak.
So based on the sleeve summit that Raul kind of like spearheaded,
yep.
The thought process for chronic leaks like this will not work with stenting. And that was the consensus, you know, from most of the thought leader in this area.
And the data on gastro-bronchial fistulas would support that, which is that the utility is really limited by the chronicity. So these patients show up an average of more than 7 months out, and at that point you have a leak of varying time periods, but you can assume it's pretty close to the same amount of time. And so you have mucosal outgrowth, and the stent's really not going to do it. But stenting, probably to the point that David made earlier, I think the endoscopic treatments are always worth trying, and the reason why is because the complications are much less severe. Stent migration is the most common one, bleeding is probably the second most common one, and you can manage those with relative ease. The challenge is that the operative treatments are all big and high-risk options. There have been no reported failures. However, the complications are severe, and in the literature there's actually one case, the most common is bleeding, requiring multi-unit transfusions, and there was one patient that needed actually cross-clamping of their thoracic aorta to control the bleeding. So
what's the mechanism of bleeding? Would you say what's
I think the mechanism of bleeding is that you have the mediastinum, the lung, the pleura, the diaphragm, and the entire upper left abdomen, including possibly the spleen, that start kind of oozing on you when you try to get exposure. And so when you see patients for these, I mean, most of us would take a laparoscopic approach, and the way to fix these chronic leaks is really to just resect the area that's leaking. And if that resection takes you all the way up to the esophagus, you do an esophagojejunostomy, and that's where most people have had success. And that, in this patient that I just described, is what ended up coming to after stenting and drainage and primary repair and multiple debridements. It was esophagojejunostomy that ended up being the ticket. You have to debride the diaphragm and get rid of all the necrotic tissue. You can either do that from the abdomen or from the chest. The lung resection is rarely necessary, although it's been employed. And then if you're doing a thoracotomy, you have to remember that you might be reconstructing the diaphragm, so you should keep your take down the intercostal as a vascularized flap. Coming up on the 6 minutes, the grand mother of all operations here is the thoracoabdominal exposure. And so the thoracoabdominal exposure for this problem is actually ideal because you can see everything in one field. I think the challenge is that the expertise of thoracoabdominal exposure has become rare. I think the last time I did one of these is 20 years ago. So you have to find someone who can do one and do one well because of the bleeding risk. But if you can find someone who can do one of these exposures and do it well, probably an aortic surgeon would be my first choice. Then you can actually see the entire area in one field. You can do a proper debridement and actually just resect the entire area of leakage and put back together from healthy proximal to healthy distal. But so this patient ended up, the big thing, the takeaways, these are very rare, but you have to think about them all the time. And so any patient that has long-term problems, especially a cough or a pneumonia of unknown source, if they cough up a clip, then there's not really a mystery of what's happening. Source control is essential, and without source control, you're wasting time. And the very first time you meet one of these patients, you have to tell them they're in for a long course, like 6 months. So this person had the index operation. They got their pneumonia 4 months post-operatively when the GBF diagnosis was made, and they got their definitive, very big operation, esophagojejunostomy, 5 months after presentation and known diagnosis of GBF, and then had to recover from that. So this was a full 1-year process from end to end for the patient described, and healthy 36-year-old. So tell patients they're in for a long ride. Just these folks helped me gather data on this patient, and as well as Stacy Bredhauer and John Rodriguez, and I appreciate their help. And that's it.